Welcome back for our third segment. In this segment, they've asked to look into the future. And at my age, I'm hoping some of my future is fishing up in a mountain lodge some part of the year. No, if I retired today, and I can't tell children this, I would go back and volunteer doing the same thing I'm doing now. That's how much I enjoy it. I am enjoying it by things like this. On the left is Aruba. She's from Jordan. She was sponsored, and I am the training site for Operation Smile speech pathologists. So every year, it's usually about a dozen or so speech pathologists, and I'm not sure exactly how they pick them, but they try to pick areas in different countries where there is a potential for developing craniofacial teams. And when I was president of the Cleft Palate Association back around 2000, I was talking a lot with Operation Smile and Smile Training, probably the two biggest groups that fund mission trips, and they do a lot of good work. But I'm telling them, and talking right to the directors, if the surgeon was successful within the first year of life of fixing a palate, by best Western standards, you still got 20% of the kids that are going to have a VPI. What are you going to do for those? Since you're not getting them in the first year and you're getting them at 5, 6, 10, 20 years of age, you have 100% of your patients. You may do a beautiful job on the lip. That individual can walk in their society. They still can't communicate. They can't participate in society. So I would love to go on mission trips and help. I hate traveling. So what I do is I bring kids to us. Aruba's job was that she spent 2 months with me to learn all the equipment, learn all the clinical skills. She shared a lot of stuff with me. I've learned a lot about Jordanian Arabic, and teach her how to use this instrumentation. And then she went back and created Operation Smile Jordan with all of the instrumentation available. And now she's got her first publication ready, looking at American Emirates Arabic and Jordan Arabic for nasometry. Said the first thing you have to do is establish some norms, because we know that British English and American English, we have two sets of norms. Different Hispanic languages, we're going to have different sets of norms. So you have to know what's the norm for the language as it's spoken. I think Philadelphia needs their own set of norms. They're very nasal up there. But I hope that this is my future for the foreseeable future, which is to work with speech pathologists from around the world. In the bottom picture, Kara was working with me. The blonde was doing a practicum with me. She's now working with Eric Stelnecki in Hollywood, Florida. She's done presentations now. She has a master's, and I know that was one of the questions that come up. What kind of a degree do you need? She has been very, very productive, and she's a wonderful clinician and a wonderful person. And then in the middle is Jennifer Dudka, who also happens to be a Gator. And she is from Bauru, Brazil. We see 150 newborns every year. They see a couple of thousand, because in Brazil, the medicine is regionalized. So she's at Centrino Hospital in Bauru, Brazil, and the whole hospital is dedicated to craniofacial disorders. They have, last I talked with her, 50,000 kids they see annually. 50,000. So I'm hoping that that's my future, is because it's just stimulating to learn from people, to learn the cultures, and to help people from around the world. Some of my perspective is not quite as joyous. When I got to Atlanta and they asked me to write a pro forma, if you're going to start a speech lab here, write a pro forma. And I said, well, my mission, and this is when we were just Scottish Rite, I said, my mission has to be that I'm going to provide outstanding clinical care. That clinical care is going to build a population of kids that are going to come in, we're going to be able to evaluate those children. So we're going to do research, and we're going to do the best clinical research we can do. And that clinical research is going to be presented. To an administrator, that means marketing. And I like the way they looked at research means marketing, because they were willing to market. And I said, you have to have those three things. When Eggleston and Scottish Rite merged, that was the mission statement, to provide excellence in clinical care, research, and education. They've since changed it to now we're dedicated to all better or something like that. But the fact that my employer and I meant a lot. I could work there, and that's important. But those are intertwined, and I hope one of the messages you guys get from this is all of that's important. You have to be a smart clinician. You have to be a good clinician. You have to keep good records, because you're going to be publishing. It may be a report that some insurance company reads, but that may mean whether you get paid or not, whether they renew that kid for 6 months of therapy or not. And it may be at that level. Or it may be that you start saying, I'm going to present at Gisha. I like this so much. I'm going to find some people, I'm going to partner with some people, and I'm going to present at ASHA. We have a technique that we've studied, and I want to do a study session at ASHA. That I hope that you get stimulated to that much. I'm very concerned that we will never stop labeling hypernasality as a voice disorder, and what hurts me is that all the kids that get caught up in that we actually, by our policies, create speech disorders. And as we've talked in the last segment, what does that mean in terms of a child's psyche, what they think about themselves? We may be doing even more harm than we know by not identifying these kids correctly and treating them appropriately. I worry, and some of this comes from when I have practicum students, because they're going to be there minimum of 8 weeks, hopefully 12 weeks or more, and I'm trying to teach them pressure flow systems, which is a little bit more involved than the nasometer. It's only got 2 microphones are joined. It's pretty much worst thing you do is turn the microphones upside down. But if you've seen pressure flow studies, you might have a little oral catheter that goes in the nose, one that goes in the mouth. You might have a mask that goes over, collects oral airflow and everything. And they started asking me, now, is that the study where I put the tube in the mouth or in the nose? And I go, you're going to be a technician. A good technician can follow orders. They can put all the leads on in the right place, and they get a great AKG or an EEG. They don't know why they did it. They don't know anything about that patient. They don't know what it means. They've got to give it all to somebody who can. Or are you going to be a clinician where you evaluate the child, and I want you to appreciate your ear sets up the problem list in terms of what we do for speech, language, voice disorders. It sets up the problem list. That if you hear hypernasality, well, there's certain structures that you have to evaluate. It helps if you know the muscles, the bones, the cranial nerves that go to all of that. It helps if you know how to run a nasometer. It helps if you know what all that stuff means, because it's nice to have the perceptual features, the measures of your ear written down, but it's even nicer to have some supporting evidence, like a nasometer. It's nice to say there's a hoarse voice, but it's even nicer to know what you need to know about the lamina propria, what do you need to know about the epithelial layer, the mucosal wave, all those things I know that Dr. Hapner talked to you about. You need to know all the muscles, the nerves, how the respiratory system interacts with the laryngeal system, because you don't have both of those, you don't have voice. It helps if you know all of that, and it helps to know that you can use the CSL, the Visipitch, or something like that, that you can actually quantify all of that, and you know what that means. I hope we're raising a generation of clinicians, not technicians. It scares me to see some of the books that I see people looking at ASHA that are just cookbooks for stuff. I hope they're not just putting a kid through a cookbook, that you're actually sitting down with your mentor, with your supervisor, and saying, oh, we got this, 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 this. These are the disorders we see. This is based on what we know about current clinical knowledge. This is what we're going to treat. And then we're going to come back and measure. Was our treatment successful? I know in this group I'm talking to clinicians, not technicians. It scares me sometimes because I'm working not only with practicum students, but I'm interviewing people that are 1 week past their practicum, and they're interviewing with me for a clinical fellowship. And I asked somebody at the ACPA, American Cleft Palate Craniofacial Association meeting, because she was doing a presentation on her thesis, which meant a lot. She was interested in research so much she was doing a thesis. And sometimes people think I'm intimidating because I ask questions, and I don't do it to be intimidating, but I just want to get a feel for things. And I asked her what her fundamental frequency was. And this blank stare came over her face, and she blurted out 14,000. And I asked her later in the day, what it was down to like 500 or something. And I had gotten a real strong letter of recommendation from a good friend of mine. And I said, please tell her what her fundamental frequency is. And right away, my impression of her basic knowledge, am I going to have to take this person and go back over head, neck anatomy and speech science and teach them all the basics of human anatomy, physiology, and what all these measures are? And then I'll always ask, what would you think? What would you think? Got a friend, third year med student, fourth year resident, some level. He's not attending yet. And you ask him, what's normal hemoglobin? And he said, I don't know. Would you want to go to him as a physician? Probably not. Well, I think the clinicians graduating today need to have a strong background in just what is normal function. And if I were the ASHA god, I'm not sure how, I would probably do it morning, afternoon, that you would have normal function lectures in the morning. And then later in the morning, you'd just be doing evaluation of each other, of normal subjects coming in, normal patients coming in, so that you get to measure those normal functions. So you immediately apply it. In the afternoon, you have a nice hearty lunch, a cup of coffee to keep you awake, because then we're going to talk about dysarthria. Why dysarthria? Because it's all on the table. All of motor speech is on the table. And especially if you've got trauma. Trauma is so great to evaluate. Why? Because you have to be on the lookout for upper motor versus lower motor versus just physical trauma, pieces and parts missing. And unless you know normal anatomy and physiology, you might not know that a part is missing. You might not know that a part didn't form in a child. That's the way I would do it. And then you would be seeing all those patients in the afternoon. And again, you would immediately apply it. If I have one big fault for our profession, that we got great academicians, you got great clinics. It's not the same as being at Northside Hospital or with Dr. Hapner at Emory or with me in the craniofacial program. You will see, and I tell patients that, I tell the students when they come in, or even the fellows, I'm going to be your mentor, and I'm not going to be your primary teacher. Each patient coming through is going to be your primary teacher. I'm going to teach you what that means. And I'm going to remind you with each patient why you need to know all those normal processes, all those disorders, all those this, that, and the other thing. I would hope that you continue to stay inquisitive. You've asked some great questions here. Think about every patient is, what is it that I can ask about this patient that's going to help me do a better job? Stay inquisitive. Don't stop asking why. Why did this happen? Why did this kid develop this way? Why did my therapy not work? what do we do different? What do we do better? What did I miss? And then when it all works, congratulate yourself. Pat yourself on the back. You evaluated, you came up with a correct assumption, you did a great therapy, and everything got better. But just how can we make things better? That was Christy Benoit, and I learned she's Canadian. It was her biggest problem. I learned more about the immigration process of the United States and Homeland Security. I kept telling her, I can't say it on tape. And then the gentleman in the middle has a cleft. He was treated in Atlanta, very, very wealthy now, and he started a foundation because at 50 he realized he'd been doing all this work with Aflac Cancer Center, and he had contacted the Cleft Palate Craniofacial Association, said, I need to give back to kids that were born with what I had. And they put him in contact with us, and we became very good friends, and he's helped fund some of the fellows. Stay responsible. And I know you guys get a lot of information on evidence-based research. Look at ads in ASHA. What is the evidence behind this? Look at some of the displays in ASHA. What's the evidence behind this? How do you develop as a clinician and a researcher? And the routes, I think, are very similar. You find a mentor. And as we talked about during the breaks, you guys have been partnering up with people where you just click. It just clicks. This person teaches me what I need to know. They answer my questions. They're not intimidated by my questions. They don't look at me as a waste of their time, taking up too much of their time. They don't go every time I ask a question. Volunteer. At South Florida, some studies had just been done, and they showed that students did better, college students did better if you volunteer. So we all had to volunteer in the clinic. So we bought Clarence Webb, great guy, but very cheap. He was the Clark Howard of speech pathology in South Florida. He bought this old artillery van that he was going to use as a portable hearing aid booth. And it needed painting. So I learned how to use a power sprayer. He wanted, videos were just coming in, and he wanted to put up video monitors in all the therapy rooms with this big bank of monitors where you could sit and watch them. But he needed a place to keep all the monitors. So he bought a bunch of angle iron, and we learned how to weld. And I'm not sure how long they stood up. At least I graduated, everything was still standing. Think of every patient that you see as a single subject design, and you'll always be honing those questions of how, why, what, where. And as I close this, I want to thank, some of the people that have meant a lot to me. Clarence Webb was the one that told me that, first Dwayne Logue was my mentor at University of Miami Mellman Center, and he said I needed to go on and work, that I would learn more before I went on for my PhD. And I got back to South Florida and I talked to Dr. Webb about it. He said, yeah, you're right, you'll learn more. But you're better off learning with a PhD salary than a master's salary. And remember how I always followed the money? Well, I followed the money to the University of Florida, where I worked to Bill Williams, Ken Bazak, got that one fellowship with Robert Blakely. Jennifer Horner did her PhD with me at Florida. I was 1 year ahead of her. I was at Lancaster for 3 years. She was at Maryland. She was at a VA hospital. And then we were at Duke for 17 years together. We were together longer than most marriages. And we were just constantly stimulating one another's interest, and we did a lot of writing and publishing together. And I hope you can find, when you get beyond needing a lot of mentorship, you need a colleague. And Jennifer was one of the best colleagues you could ever have because we just clicked. So I hope everybody has somebody like that, whether it's a research colleague or in her case, we were both clinical. We went to Florida because we wanted to become clinical researchers. So we had that same bent. And then you're going to get to the point in your career where you're the mentor. All of a sudden, you're teaching. And it may be somebody that just wants to shadow you because they want to say, what's the life of a speech pathologist like? Or somebody says, would you take practicum students? Then you find out the lawyers got involved in the practicum process because it used to be a phone call and a handshake, and now it's this contract, that contract, medical this, medical that. It's a crazy world out there. And lastly, my wife and Madison and Meredith, and I hope for our kids as I hope for you, and Bob Mason, who was speech pathologist, went back, got his dental degree at age 40, got his ortho master's at Carolina, and then we hired him at Duke. And he and I worked together for the 17 years at Duke, and he's still, we would always say we're more like brothers to each other than we are to our own brothers, just because of the way we got along. My wife, who's her AUD, and because she saw the writing on the wall, she was going to have to get it. And Ramey Tritt, the ENT that owned the practice she was working with, paid for it. I blame Ramey for the reason I'm still in Atlanta because he made my wife's life there too comfortable. We both have a passion for what we do, and we hope we've instilled that in our kids as we talk. The one without the teeth is at Purdue. She's got a passion. She's working 2 days a week at the CDC. It's a non-paid position, but just to get in there and to have that on her resume. She said, Dad, there were some researchers coming out after lunch, and they were talking about viruses and stuff. And he said, I knew what they were talking about. And I've never seen her get so excited about something. But she is so excited about her career. And then the TUD, we're not sure what's going to become of her. We just hope it's not a life of crime. But I have to say thank you to them. And thank you to you. We've got time, I think, for a couple of questions as we close out this section. If there's anything, get all your questions answered, then thank you so much. Go Dogs.